morning, everybody, and thanks for the opportunity to present this morning. So I suppose Wither or Evolve, and my talk is very much founded around that and looking at sláinte care and the opportunities, but also the potential risks and where palliative care needs to place itself in the coming years to be, as it has been, a dynamic and evolving specialty. So I think our first steps are always to sometimes look backwards and learn from our past. And it's interesting, if we look at the history of healthcare, particularly healthcare in Ireland, that there are some common themes and trends that keep coming up. So if we look back towards the 5th century, we had the first almshouses created in Ireland that cared for those who didn't have resources or the ability to care for themselves or families. Around 1720, we had the establishment of the first formal hospitals and the voluntary hospitals. These were formed and funded rather by legacies, donations and subscriptions. And they were divided into two groups. We had curables and incurables, and they were the words used at the time. And many of our modern hospices in Ireland would have been founded initially from what institutions that were described as incurables. I think we could substitute that word for chronic care, and I'll come back to that theme as I'm going through my talk. We've obviously the workhouses, which are very synonymous with the famine and pre-famine in Ireland, which had I suppose, a utilitarian aspect for the state in terms of providing work and particularly engaging in public works, as well as caring for those who couldn't care for themselves. We had fever hospitals, and Ireland probably led the way internationally in recognizing, long before Louis Pasteur described germ theory, that there was a contagion or a contagious element to many of these diseases, and built fever hospitals with adequate ventilation, often on elevated sites, and the idea of isolating and quarantining those who had infective illness. And this was long before this was the established practice in medicine. We know the Poor Law of 1938 had, I think, what was a primitive medical card system with red and black tickets. These were often dispensed by significant members of the community, the church, teachers, elected representatives, and these entitled you to free acute care and free care at home from dispensary doctors. Our next major significant change was the funding of hospitals. And we know that at the start of the 1900s, subscriptions and legacies and donations to hospitals reduced. And the state took on some of the formal funding of hospitals through the hospital sweepstake program, which was run by a private company similar to the National Lottery. And the sweepstakes was in operation until 1986 and was responsible really for a huge rebuilding of our public hospital infrastructure during pre-war and post-war. In the 1920s, our workhouses became essentially started evolving towards becoming community nursing units and county hospitals. The Department of Health was established in 1947. Initially, Dr. James Ryan proposed a national health service. This was bitterly opposed by church and state at the time, and the compromise was a policy to eliminate tuberculosis, again by the development of fever hospitals and quite a broad spectrum approach to tuberculosis, which was internationally been, with the lens of history, has been viewed as very positive. In 1953, we had the Healthcare Act, and this is where the modern medical card, as we describe it, has its foundations. It was for those, it was means tested, and also the state formally took on increased funding and responsibility for acute care. In 1957, because of the means testing of the medical card, the voluntary health insurance was established to provide others who could pay for insurance to fund their healthcare needs at times when they needed it. We know in 2002, and actually last year, we had returned to pre-recession levels of with almost 50% of the population having some form of private health insurance. And this is important in terms of looking at sláinte care, which I'll move on to now. In the 1960s, we saw contribution to funding of hospitals increasing from the state. And if one of the things that happened was that if you couldn't afford GP care in the community, acute care was free. And that was, again, has created, and I think that impetus is still there for those who don't have free GP care to drive them towards acute care. In 1970, we had the Health Act, and many of us commenced our careers working within the health board system, which had devolved responsibility and funding to provide healthcare in a region, and there was 8 regions in Ireland. We also had the formation of Cohorla and Ospedale, which regulated and put a systematic approach to the appointment of new consultant posts and trying to develop specialism. We know that private hospitals were developed significantly in the 1970s in response to the VHI and people having health insurance and a funding stream for that. So in terms of looking at modern times, we know that the HSE, the HSE was formed by Minister Mary Harney in 2005, and initially that separated out from the traditional health board, separated out community and hospital care. We had the Programme for Continuing Community Care and the National Hospitals Office. The first CEO was Professor Brendan Drum, who I'll come back to in a moment, but he immediately implemented a transformation regime to bring them back together. And we had regional directorates and regional directors of operation where we managed community and acute care together. And the next major change was in 2011, Fine Gael, prior to and when they were initially elected to as the majority party in government, proposed universal health insurance. However, over the following 2 years, this was parked due to what was anticipated to be the increased costs associated with this, which were relatively modest, of about 8 to 10% per year. In 2013, we had the Professor John Higgins report on hospital groups. And here, again, we migrated from connecting community and acute care and separating them out again. And he proposed academic hospital groups and that community care would be a separate entity. Then in 2017, we had the Committee on the Future of Healthcare, which was chaired by Deputy Roisin Shortall. And that developed what we now know as Sláinte Care. And this was in response to what was seen as a 2-tier health system with different access and equity of access to citizens of our state, depending on their ability to pay or their health insurance status. It was proposed a universal single-tiered health service with access based on need rather than income. Maybe to highlight some of the initial report, the universal healthcare system will provide population, promotive, preventive, primary, curative, rehabilitative, palliative health and social care services to the entire population of the state, ensuring timely access to quality, effective, integrated services on the basis of clinical need. That was a 10-year plan with a finish line initially of 2028. We had the appointment of Laura McGahey as the CEO of Sláinte Care. It also proposed a Carta Sláinte for every citizen, entitling them to free care, both in community with their GP or otherwise, or in hospital. So I think one of the other things often we hear in the media is about the cost of care in Ireland. So I'm not going to blind you with figures and statistics, but just in overall terms to describe, in terms of effective public healthcare systems, there's probably 2 well-established models. There's the Beveridge model, which is similar to the NHS, which the NHS is and named after. And that is probably the system that we're closest to. And that's a state-funded system. And then you have, similar to Australia, and then we have a Bismarck model, which is a universal health insurance model, and Germany and Belgium use these models. I think either of these models is effective. I believe any system, once it's utilized and backed, will deliver outcomes that are needed. In terms of GDP, we often hear this. Ireland actually has a relatively low percentage of its gross domestic product reinvested in healthcare. But I would err some caution with this in terms of the economists tell us that a lot of international companies, their finances are recorded through Ireland for taxation purposes, and this can negatively make some of her GDP contributions to public services look smaller. So the second column here is price per person in dollars, the cost of providing a public healthcare system to the state. And you can see that while we're at the top of that, there's actually quite similar figures in terms of across different countries. Interestingly, Australia and UK at the lower end, and we're at the top end. But the differences are modest. And I suppose the other note of caution with this is that there are differences in how these figures are calculated, including social care. Some countries do and some don't. So one of the things that Professor Brian Turner, healthcare economist in Cork, has noted that we certainly had underinvested in our healthcare system during recessionary times, namely the 70s, 80s, and early 90s. And what suffered was our infrastructure. And I do believe our hospital infrastructure in this country and our community nursing units are way behind. And this was exposed to some extent during COVID, where we didn't have all single room capacity. And so our infrastructure development in this country does lag behind some of our international neighbours mentioned there. So in terms of Sláinte Care, one of the core ethoses of it was to promote the engagement and the empowerment of citizens in the care of their own health, to scale and share examples of best practice and processes for chronic disease management and care of older people. And I think this is really important, that all of us tended, when we entered healthcare, to think of almost all healthcare being accessed through acute care, which tends to be focused on reversibility, on disease markers. We know that countries that have established successful chronic disease management programs, that tends to be based on patient goals and preservation or restoration of function. And I think that is a challenge in Ireland, that until Sláinte Care, a lot of our chronic disease management and focus was through acute care. Sláinte Care also looks to encourage innovations in the shift of care to the community and provide hospital avoidance measures. I would argue that appropriate should be in there, appropriate hospital avoidance measures. But we know, because of not having other routes of access to care in this country, acute care has served, and still to a larger extent, as the only access point to care, particularly out of hours. So, and also the phrase that's been coined with Sláinte Care is the right care, the right place, and the right time, and the right person has been added on occasion. So its aspiration or vision is that all people and communities can use the promotive, preventive, curative, rehabilitative, and palliative health service they need, of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. I think we have a long way to go with this. So Sláinte Care proposed a population-based approach to planning services, as opposed to a county-based approach, a regional-based approach, or a political-based approach, which have all been our traditional ways of doing this. We've seen that established hospitals tended to be funded and developed, as opposed to looking at where the population or demographic need, including social deprivation, where that need was. It aims to provide clear pathways between GPs and community and social care services and hospitals within geographical regions. It also aims to have empowerment of frontline staff and devolved responsibility and decision making. And again, this is a significant change to our current system, where we have a centralized management of the HSE, and by having budgets which will be devolved to 6 regional health areas, or 6 regional health areas. So as I mentioned, the Carta Sláinte was proposed. We've unfortunately already missed the deadline of that. That was supposed to have been in place by this year, that universal access to free primary care or GP care in the community. And also there was some other goals which are noted up there. One of the other recommendations was to have significant funding for palliative care, an increase in funding, and palliative care was mentioned and forms a strong theme of the original Sláinte Care document. And it talks about increasing palliative care funding by year 5 and having universal access to palliative care, not based on health insurance or ability to afford or geography. So back to Professor Brendan Drum, the first CEO of the HSE. Professor Drum, I believe, laid the first seeds of Sláinte Care. He wrote a book which is an interesting read, and probably a reflection of his experience as CEO, which was as for any CEO or Director General of the HSE, was during a challenging time. And the title of his book was A Challenge of Change, Putting Patients Before the Providers. And he tells a story. I have a picture of Ballybofey on the right there. He tells a story, many of you may have heard this, of Tom from Ballybofey, Tom is an older gentleman in his 70s who has depression. Tom is an alcoholic. He doesn't have family supports, and he's type 2 diabetes mellitus. In terms of inputs to his care, he has a GP who goes to visit him occasionally, or if other healthcare workers direct, Tom comes to visit his GP. He has a public health nurse who attends him at home, helping manage his diabetes. He has a community psychiatric nurse who visits, again, separately to other services. He has home help, visiting a number of times a week. And then Tom develops symptoms of hesitancy, urinary hesitancy, is admitted to his local hospital, is then transferred to a large Dublin hospital where he has a biopsy and is diagnosed with prostate cancer. At that stage, they notice that he's an ulcer on his lower limb. He's transferred to another hospital and then transferred back to a community care facility, back to his hospital in Donegal, and then back to a community care facility. So I think Professor Drum's point with Tom is that there was lots of different services inputting to Tom's care, but they weren't connected or integrated. Everybody was working to deal with their specific issue, be it psychiatric or otherwise, but the care wasn't joined up, and there was a lot of visits every day. And this is something I hear commonly from our patients, so the patients that we care for in the community with palliative care needs, that there often are a lot of people in and out of the home, and the care isn't always efficient. So some of the reoccurring trends as we look at history and we look at where we are now, that there is that challenge of that constant challenge between hospital and community. I experienced that myself, that when the hospitals come under pressure, as we are at the moment with our clinical winter and a degree of COVID, that there's a sense of them and us, or the hospital versus community and primary care. And I believe that still exists. And I think I would be supportive of Sláinte Care of connecting those together and not separating out the care of patients, that it is allegedly a healthcare system. And I think we need to manage it as a system and putting patients at the center. As I said, acute versus chronic care, I think we have some distance to go with this. We've had some very positive developments with Dr. Orla O'Reilly and the development of the chronic disease program, and also some of the other clinical leads, namely for heart failure at the National Dementia Office, Professor Suzanne Timmins, and Dr. Ken MacDonald with the cardiac failure program. But still, I think we still don't have a clear sense of that. We know that the majority of people admitted to acute hospital, many of them have chronic illness that tends to be managed in an acute care paradigm. And there is that constant struggle with that. We know that the universal access is still not established, I believe, and we still have a two-tier healthcare system. And I think actually that's going to be more evident in the coming years with difficulty accessing elective care and imaging, that we unfortunately will see a greater differential between access times for patients, which may or may not be based on need. I think the other difficulty is with, as our health system is, it's a public service system. There are very established professions within that, and there's a degree of inertia to change. I think there is also within those professions, and all of us are part of that, that there is trade unions and union representation where any change is initially resisted, even if it is generally accepted as being the right thing. I think there are difficulties we've seen even with the inception of Sláinte Care and with the network managers, with reporting relationships, having one discipline reporting through another discipline in terms of trying to have team working. So there are lots of challenges. And I believe that does compete with the needs of individual patients, and also with patients in general, that there is that tension there and an inertia to change, which is probably the biggest challenge in our health service to reacting and changing to things. Interestingly, we saw during the pandemic an ability to flex, but it took a crisis. And I think we probably need to try and harness some of that energy and some of the positivity and the, I suppose, focus on doing what everybody could see was the right thing for patients to drive change. So in terms of Sláinte Care, Tony O'Brien, the former Director General of the HSE, coined recently, Sláintecare was its strategy or slogan. I think it's not an unfair comment. I think Sláintecare really is not a detailed roadmap, and that is the difficulty. It is a policy, and the change will have to come from all of us working in palliative care in other areas, and us engaging with other stakeholders, and having what I call a significant system redesign or co-design with patients. I've talked about the public service challenges, our effective use of public patient interest representatives. I think we're only at the start of the journey. And it might be interesting to ask all of you now, all of us sit on numerous committees, groups within healthcare related to governance, management, quality, clinical audit, and how many of those groups have presence of a public patient representative or a service user representative? And maybe to reflect on how many should. And I would argue anything to do with quality assurance, to have authenticity and a focus on what's important to patients, has to have public patient interest representation. The organization that Norma mentioned I'm involved with, the National Office of Clinical Audit, on every committee, including our board for that organization, we have 2 PPI reps. And I think that is a better position to avoid tokenism. We try to encourage skill match. We look for those with particular skills. We look at tenure to make it attractive, that they're not, it's not like the age old that if you take on a position on a committee, you have to find your successor before you can leave. So I would suggest it's not ask what Sláintecare can do for you, but what you can do for Sláintecare, what we all can do. And this is part of the evolution of palliative care. And I do believe we have an advantage in that palliative care, being a relatively new care domain in healthcare, has evolved. What we were doing 30 years ago is radically different to what we're doing now. We talk about an early intervention of palliative care with better outcomes. We probably should call it needed intervention or on-time intervention. But we're constantly evolving. But perhaps some of our systems and structures are based around our historic structures, around buildings, around domains and services. And that's where we have to work, to genuinely work in partnership with other services to help educate them, help them identify the needs of those patients. An editorial back in 2016 in Palliative Medicine by Jerome Hasler and Sheila Payne started to look at the integration of palliative care from idea to practice. I know many of us will feel that palliative care is well integrated, but I think in terms of true integration, we have somewhat to go. I think palliative care has developed as a wraparound service in Ireland, with some elements of integration through relationships in certain areas, but I do not believe we're rather, to phrase it in the positive, we're at the start of our journey. We've taken the first steps in integration. So in this paper, they described integrated palliative care involves bringing together administrative, organization, clinical and service aspects in order to realize the continuity of care between all the actors involved in the care network of patients receiving palliative care. It aims to achieve a quality of life and a well-supported dying process for that patient and the family, in collaboration with all the caregivers, paid and most importantly, the unpaid, those that provide care and support their family members or friends. So in terms of integrated palliative care, and this is where we need to learn from the evolution of implementation science. This could evolve in a iterative and unstructured way, but I believe that there is enough evidence to show us how to evolve this. We can identify and describe the evidence-based practice. We can identify barriers and opportunities, clinical, informal caregiving, education, implementation, I've highlighted in large letters there, and regulation. We can have we must have comprehensive implementation strategies. And I think this is where healthcare in Ireland and many of the policies over many years have failed, in that the policy has been written, but the implementation strategy has not. And that has created that inertia. And I remember hearing a colleague of mine in response to some change in policy a number of years ago, alluding to that, I'm not going to go along with this one, there'll be another change after that and I'll decide on that. So there is a cynicism sometimes towards change, and I've illustrated that we've had a lot of changes in our governance and structures in healthcare in recent times, probably due to a lot of political turbulence and changes of government and direction. And that does create a destabilizing effect and can literally sap the energy that's required for innovation. So in terms of change, we have the opportunity to drive change, and the most important resource in any healthcare system is our staff. And we have excellent, highly trained staff, and this is evidenced by the demand for Irish trained healthcare staff at all levels, in management, in providing direct care, in therapies and professions. There is a demand for these staff all over the world. And I think our challenge is how we harness that change, working with our staff, that engagement, and connecting with patients and service users and other providers of care to redesign how we provide care. So in terms of the opportunities, and I'm going to, in terms of the opportunities, I think chronic disease is one where many of us are building relationships with colleagues, and I think it is the opportune area for us to focus on. So looking at respiratory, we have chronic obstructive pulmonary disease. We know that those with advanced chronic obstructive pulmonary disease have symptom burden greater than those with advanced cancer, and could benefit and should benefit from a palliative care approach. And there are individual patients who may benefit, or would benefit rather, from specialist palliative care input. We also know with cardiac, and particularly cardiac failure, Dr. Norma O'Leary has done significant work previously in this area demonstrating those needs, and also that those that have the highest needs are often the patients who are not ambulant. They're not able to attend outpatients and so on, and often this need isn't addressed. I think the chronic disease program, working with GPs, with biannual assessments by GP practices, will create the opportunity for us to work with these patients and to identify palliative care needs in terms of using tools, and also to help patients set the goals of care. What are their goals in terms of place of care and their functional goals and so forth. Dementia is another area. Others would include renal medicine. And so there are a lot of opportunities. I don't think we're going to have a roadmap for this. I think a lot of us will probably innovate and work with local colleagues, but there is an opportunity at the national level with the clinical programs and chronic disease programs to work hand in hand and develop exemplars of practice which can be used as a template and bespoke for individual regions and areas to work together and collaboratively. So as I mentioned, the older persons or chronic disease service model, and I just realized this isn't a high-res image, but we can see palliative care is mentioned here, somewhat on the periphery, and end-of-life care here. There is an opportunity for us, I think, to be more to the forefront of this and helping shape the care paradigm here to really deliver on what's important for patients. We can see here, I think the big challenge for chronic disease is moving chronic disease management from the traditional model of specialism and in acute care to a hybrid model where patients ideally can access the specialist input, but not always having to attend through acute care, through having a true ambulatory care, or ideally through other healthcare professions closer to their home. And this is about upskilling others. It's not about everybody having specialist knowledge, but rather identifying patients' needs and those with non-complex needs having their needs met by those who are closest to the patient. So where to for integrated palliative care? So as I've highlighted, and I probably labored the point, I think patient engagement. We need to work and listen with patients. We need to, all of us, look at our organizations and I think find ways of engaging service users, maybe skill matching, finding service users or those who've had an experience of a family member receiving palliative care, to bring them in to how we shape and design our services. We need to look at the idea of key workers. As I said, our care system at the moment, in honesty, is quite fragmented at times in how we provide care, both in the community and in acute care. And we need to try and move towards an idea of more connected health. And a key worker, it might be, I often use the analogy of who's wearing the hat, who's in charge, who's driving the train today. And that could change both over weeks or even during the week, that there may be different key workers on different days who take a responsibility and a lead for that patient and link with other team members. Some of the, and I'm going to try not to be too negative here, one of the biggest drawbacks we have is not having a unique patient identifier number in Ireland. I remember back in, I think it was 1999, hearing that this was imminent, and I think it was Billy Hawkes was the Data Protection Commissioner at the time, and yet we still don't have unique patient identifier number. This really provides for, I believe, poor patient outcomes, inefficient healthcare, even when we're monitoring outcomes of patients, because we can't track individual patients across different hospitals. If you're admitted to one hospital with a heart attack and then transferred to another hospital for PCI, for definitive care, and then transferred back, you're counted as 3 admissions for a heart attack, so our denominator is affected by that. And part of Sláinte Care is this idea of population planning, patient outcome measurement longitudinally across domains, not solely focused on hospitals or in community, but crossing and following that patient. And I think we have to work with GDPR and some of these other challenges, but find a way to measure and determine how patient outcomes are doing. Most of our outcome measurement at the moment is really limited to short-term acute care outcomes around stroke and heart attack and so on. I think a shared electronic healthcare record or patient record, again, will facilitate this. We know that countries that have done this, such as Sweden, it has transformed their healthcare. They're seeing, and that has driven and allowed them to move funding to the community and reduce the impact and burden on acute care, and also the idea of preemptive care. So electronic healthcare record and UPIN are essential, and I think should be some of the key ingredients for Sláinte Care to allow us to provide integrated care for our patients. Our palliative care needs assessment document, I think this is aged well, like a fine wine, and this provides an excellent opportunity for us to engage with our chronic disease program colleagues, with our general practice colleagues. This is to develop a tool that could be a ready-made assessment for all our patients. We know in Canada, anybody attending any service as part of their cancer treatment protocols has an assessment, a symptom screening tool used. So I think we need to embed this in chronic disease or palliative care needs assessment. This will identify patients' needs and also triggers for when specialist palliative care is needed, because there isn't a need, and nor are we resourced or able to take on the management of these patients. It needs to be done in partnership and matching the need or the specialist need to the resource. This is something which I think in Ireland we've struggled to do in all areas of healthcare. So we need to move towards clinical effectiveness and efficiency. I'm conscious one of my colleagues later Dr. Mike Lucy may talk about this. And this is very similar to the slogan to Sláinte Care. Efficacy is about getting things done and the evidence-based, and the effectiveness doing the right things, and efficiency doing things right. Because we have limited resources, we need to be efficient but effective. So, and I believe this is very much aligned with Sláinte Care, and we can use a lot of tools in palliative care, such as patient-reported outcome measurements, functional scales. Peacock allows us to do a lot of this to show the effectiveness of our services, but also for us to be efficient in how we resource services. I think patient preference and directed care, I think we're only at the start of a journey on this. I know there are some who will argue that advanced healthcare directives, even in countries where they've been legally commenced, are probably applicable to a small number of patients, but I think they're important. And we know that the 2005 Assisted Capacity Act is due to commence in June of this year. I think advanced care planning is a much more practical tool that all of us can engage with, and also support other healthcare professionals engaging with. As I said, patient-reported outcome measurement and quality of life tools, and agreed goals for programmatic care. And we can learn from our colleagues in, sorry, I have a typo there, the integrated care programs for older persons, where they have often have a programmatic care, care approach to falls, to restoration of function. And I think we're probably going to see the review of what we call daycare or day hospice to this model of programmatic input by certain disciplines, with a goal agreed, and a patient's goal being met by the team. And this could transform how we provide care in the community. I suppose many of us are working with limited resources and our community team is often nurse-based, but there is an opportunity to extend that and have a programmatic approach. I think we can learn from our colleagues in integrated care of programs for older persons in terms of frailty scores, delirium screening, falls programs. I think one of the things we could perhaps take a lead on is looking at fatigue and breathlessness management. We know with almost all advanced chronic disease and malignancy that fatigue is very, very prevalent, over 94%. Should we therefore be offering any patient with advanced disease fatigue management program, be it a blended approach or an e-module, and working in combination perhaps with our local cancer support centres and other voluntary groups. So there are opportunities for us to engage, and similarly for breathlessness management. As I said, to review how we provide daycare. And I think finally, and perhaps the most difficult thing, and it's been a theme through my talk, is moving from inertia to an innovative culture. Getting it, we will get it wrong occasionally, and I think that's part of clinical audit, of quality improvement. I have the Plan, Do, Study, Act, PDSA cycles there, using clinical audit as a tool. But that idea of looking what's important for patients, what we can improve, and constantly not necessarily changing for the sake of changing, but trying to enhance and improve, bringing patients into that fold, having a reflexivity, having a responsive culture, using quality improvement, celebrating quality improvement, and celebrating with those that use our services. How many of us in our organizations, when you walk in, have our clear posters up written in plain English? This is what we did to improve something, and this is the impact it will have on you or other patients. And I think part of that communication is important for other healthcare professionals as well. If it's written in technical language, it's likely that nobody from outside the specialty or the specialism will understand it. So it's how we promote this work, having rapid cycles of change and improvement. I think sometimes we can spend too long planning a change. I think using clinical audit effectively, turning the wheel, turning the full cycle, and involving all healthcare staff. Particularly, I'm working on some projects here in Waterford at the moment with our healthcare assistants, and often those closest to the patient will come up with the best solutions to problems. Having a ground-up approach where we meet the policy coming down. And I think that's what we need to harness to develop an innovative culture, to have effective integrated care, and for what I believe to see the continuing evolvement of palliative care rather than palliative care withering, and becoming relevant and benefiting patients, and hopefully destigmatizing as well in that, so around the communication. So it's about buy-in, and it's, I think, probably most importantly amongst our healthcare staff and patients working collaboratively and service users. All of us are service users of the healthcare system in this state. Our families, everybody knows somebody who's accessing healthcare at some stage, at some time. So it's seeing it as our service and having that collective buy-in and working together, and I think initially it's about working locally at services. Thank you.